Welcome to Fertilish, the podcast where we get real about fertility, infertility, and everything in between. I'm Laura.
And I'm Brandis. And whether you're knee-deep in treatments, just starting to ask questions, or somewhere in the ish of it all, you're in the right place.
Here we ditch the stigma, break down the science, and have candid conversations about the messy, emotional, and sometimes hilarious journey to growing a family and preserving your fertility.
So grab your coffee, your meds, or just your curiosity, and let's get into it. All right, so we are back for another episode of Fertilish, and this week we are talking about endometriosis.
Yeah, I feel like that this will be super useful to so many people. I come across so many people who have suspected that they may have endometriosis or been diagnosed with endometriosis, and, are not really well informed on how that has affected their fertility and like what the relevancy is between the two, or maybe they have been very well informed and would just like some additional information and support. So I do feel like that we have a large population of people that have been diagnosed with endometriosis. So I think this will be super useful today.
Yeah, and it's crazy because so many women live with horrible pain, which is kind of a hallmark symptom of endometriosis or endo, with their menstrual cycles or, with different kind of circumstances that we'll go over, and they're brushed off or, yep, everyone gets cramps during their period, that's normal. And so because of that, it does actually take an average of 7 years to even get a diagnosis of endometriosis. And meanwhile, this disease process is just getting worse. Ovarian reserve can decrease, and we'll go over that. Or a lot of teenagers are put on birth control, which is actually, because of the pain, they're put on birth control, which is actually a way of treating endometriosis and prevents it from getting worse. But then, these girls come off of the birth control, and now they have this pain back. And think it's, all this post-birth control syndrome and that sort of thing, but it's actually been treating the disease the whole time.
Yeah, and, I think that kind of goes back to, like, what we were talking about on a previous episode about PCOS, is that, like, there's not the education piece there of this is why we're putting you on birth control, because you have this diagnosis and it affects you this way. And so that does lead to misconceptions of, birth control caused me to have endometriosis or birth control caused me to have PCOS, which is not the case. And so there's like that missing piece there that you already had it. We were using the birth control to treat it. And so I do think that there definitely could be more education surrounding the diagnosis and what implications that has.
Yeah, and endometriosis is actually one of the major causes of infertility. However, not everyone that has endometriosis will have trouble conceiving. But 25 to 50% of those with infertility will actually have endometriosis, and then 30 to 50% of those with endometriosis will have infertility. And so just because you have it, just like PCOS, doesn't mean you're going to struggle, but there is a big prevalence. And, as far as what it is, it's when so you have a lining in your uterus called the endometrium, and this is what grows in response to estrogen and then sheds every month when progesterone drops in your period. Those endometrial-like cells are actually outside of the uterus in places where they shouldn't be. So this can be, on your ovary or even in your ovary. Common is behind the uterus and the posterior cul-de-sac. It could be on your diaphragm, your intestines. So these cells can implant outside and really where they're not supposed to be. And every month they're responding to that estrogen and being stimulated or growing, and it just causes this big inflammatory process. There are stages of it, so 1 through 4, ranging from mild to severe. In those first, stages of 1 to 2, that inflammation is pretty drastic. And then in stages 3 and 4, it's severe, but it's more of like a chronic inflammation from just a long time of being exposed, basically.
Are there factors that, I'm sure there are, that exacerbate, moving from one stage to the next, as far as like external factors?
External, a lot of endometriosis is still somewhat misunderstood, and it's because we don't necessarily know the cause of it. One thing that, or I guess what I kind of believe as far as theories go, and we'll go over the theories, is something called retrograde menstruation. So if you think your uterus, you have a cervix that obviously is where the menstrual blood comes out of, and then that's where you get a bleed. But you also have fallopian tubes that are connected to the uterus, and if they're open, that blood can actually go, or those red blood cells can actually go out the fallopian tubes and get on, different places outside of the uterus. And we know this because, just coincidental findings of people that, let's say, have had an appendectomy. When women are on their period, we see, or they do see, blood outside of the uterus on kind of different organs. And in a normal person, that's fine. Our body will just say, oh, yep, this person's on their period. It'll shed, go away. Endometriosis is kind of an autoimmune condition because in their bodies, they see these red blood cells that have migrated out the tubes and are kind of in their peritoneal cavity, and say, oh my gosh, these cells are not supposed to be here. Let's start attacking. And then that's where you get that inflammation. Some kind of other theories are germ cells that when we're embryos or when we're really not born yet, implant in places where they shouldn't be. So those endometrial cells are implanting outside. Some people think that these cells can, are transported along our vascular or lymph system and implanting. Other people, what other theories are that it can be a direct transport. So we know that women can get endometriosis in their C-section scars. So any surgeries, C-sections where we're cutting into the uterus, we kind of give those cells a direct path out. It could be a combination of these things. We don't 100% know. We know it's multifactorial. So as far as outside things, it's an autoimmune condition. So we want to optimize lifestyle. Don't smoke, control things we can, control stress, get sleep. Those things can affect inflammation in the body too.
I'm sure diet.
Yeah. Diet. So yeah, there are, a lot of outside things that anything usually that's good for your health is good for fertility health, and I always tell people that.
Sure, absolutely. And then obviously medications. So like medications that increase estrogen are obviously going to have some type of effect on the endometriosis as well.
And actually, and this gets brought up too because, we treat it with birth control and people will say, well, that has estrogen in it. Can't that make it worse? And so in a normal cycle, you're right, that estrogen kind of, it stimulates those implants that are outside of the uterus and can just continue to make them worse. And this gets worse with every menstrual cycle, even when you're trying to conceive. So with birth control actually has a different type of estrogen that doesn't stimulate those growths outside the uterus.
So it's kind of regulating it.
Yeah.
Okay.
So not only are we, preventing those growths from being stimulated, but we're also preventing ovulation. So you can have something it's a very late stage of endometriosis called endometriomas, or they're sometimes called chocolate cysts because when you cut them open, it kind of looks like old period blood in there. They're gross. But you can get those. And the reason that those happen is because when you ovulate every month, a follicle, which is a fluid-filled cyst that an egg is in, will burst and you ovulate that egg out of it. Well, while that follicle is open, endometriosis can actually sneak its way in. Because there's a ton of blood supply there, it loves all the hormones, so it can actually go into the ovary, and you can get what's called an endometrioma. Those are seen on ultrasound. If we do see that, in the follicular phase and it's not confused with the corpus luteum, then we know, oh yeah, you have endo, and it's a late stage. And that's actually one way you can get a diagnosis without surgery, is by seeing those. So by preventing ovulation, we are also preventing that endo from getting in the ovary, which can affect egg quality and can actually decrease ovarian reserve pretty drastically.
It's wild that it's that fast moving. That it just...
Yeah. And it's crazy because so many people, and this is why an earlier diagnosis is so important, because the sooner we can control it or put people on birth control or, find ways to kind of manage this, whether that be surgery or whatever, which we'll kind of go over, the less impact it's going to have on your symptoms, your fertility, your egg count. So all of those things and catching it early is super important. Even if you do IVF, since we are limited to the amount of eggs that you have left.
What would you suggest for a patient who may have had like super painful periods for a very long period of time? They go to their OBGYN does a transvaginal ultrasound. They say, oh, well, we don't see anything. Everything looks fine. But they're still very much suffering with super painful periods. It's affecting their quality of life. Maybe they're missing work. Maybe they're missing, social activities. And, I know sometimes people can even have painful enough periods to where, they're having to go to the emergency room, or it's making them nauseous, or what would you suggest to be the next step for a patient that maybe they've had that experience?
Yeah. Well, so you bring that up. So what's crazy is that in teenagers, those that have severe period pelvic pain, or pelvic pain during their period, and when I say that, we call it dysmenorrhea. This is like debilitating pain. So you're having to cancel time with friends. You're missing school. So it's debilitating. Of those teenagers with this symptom, 50% of them will actually have endometriosis. So I would say, so pain obviously is the biggest symptom, with periods and also with intercourse. So, and this isn't just like penetrative pain. This is, or like insertional pain. This is actually deep pain, because those endometrial deposits are can be behind the uterus. And so in positions that allow deep penetration, you can actually have pain with intercourse. You can get those implants on your intestines, so you can have GI issues that kind of go along with your period. Those are kind of the main things. If you're getting brushed off and they're saying, yep, you can have cramps, these are things that can happen, you have prostaglandins when you ovulate, it can cause diarrhea, that's just normal, I would say, seek out a second opinion. And, if you're trying to manage symptoms, surgery, so having that conversation of, hey, maybe let's try and get these deposits, I guess you would say, these endometriosis, let's try and remove them, knowing that if you're going to have surgery and have these implants removed, excised or ablated, that you should get on medication or hormones after the surgery, because if you don't, it's just going to come back. So yeah, get a second opinion, and then, talk about ways to start either getting a diagnosis or treating it.
Yeah, that's really good advice. 50% of those patients having endometriosis, that's a staggering number. And so, that means 1 out of 2 people who are experiencing this are going to be, have the actual diagnosis. Maybe they haven't been diagnosed, but they actually have, or I guess they have the disorder. So, or the disease process. So, that is a great chance that you do have it if those are your...
Well, and you've brought it up before that, the amount of endo you have doesn't correlate with your symptoms.
Right.
So you can have a ton of it and have no symptoms. You can have one speck of it because it can exist at a microscopic level even, and your symptoms are debilitating.
Right. Yeah. I mean, and some people don't they have no idea until they maybe have experienced infertility and they come to us that they have had it. But then when they start realizing like what the symptoms are, then they're like, oh yeah, like I've had super painful periods. Or maybe they're like, oh, it's never been an issue for me. I had no idea. So it definitely goes both ways that people, especially our patients that don't realize that they had it, prior to coming to us. I think that we see kind of the gamut of patients that have had a variety of different experiences.
Yeah, and 7% of women that actually don't have symptoms will have endometriosis, and we know this because women that have conceived unassisted and never had issues, they end up going in for a tubal ligation, and then we find endo, and they just never knew because they just didn't have symptoms. They never, struggled with infertility. And so, yeah, it's easy to kind of either get brushed off or not know, and then this process and inflammation just continues to get worse and worse.
Well, and I think that it's very important to point out something that you brought up earlier, is that, I think that women's symptoms with, in regards to their periods are downplayed quite often, and historically that's been the case. That's kind of where the, women are hysterical. That's where that comes from, as, us being emotional, moody, exacerbating our pain levels, without warrant. And so historically that's kind of been the way that it's been looked at, that, oh, it's not really that bad. But people have true diseases that come with, a lot of symptoms that are a lot worse than just a normal period cramp. And I think that a lot of times, it can turn into someone not being listened to, and saying like, hey, this should not be how I live. Like, this is,
Yeah.
This is not normal.
Yeah. So don't accept that as your normal. And it's okay to get second opinions. I could speak for us here. We don't get offended if you seek someone else out, but I think everyone that works here is pretty good at listening to people and taking symptoms seriously, especially because we do get the people that have been brushed off and now are having infertility issues because this process has gotten worse.
Absolutely.
It is also, we know it's a genetic, you can have a genetic predisposition. So if you have a first-degree relative, like a mom or a sister that has endometriosis, you actually have a 6 to 7 times more likely chance of having endometriosis as well.
Wow, that's huge.
So that's why even in our history, when we ask about symptoms or, have you had endometriosis, we'll ask about, a mom or sisters that have it, but just because we do know that it's autoimmune, it's genetic.
That's a pretty large, added chance to having 6 to 7 times. That's staggering. Yeah.
Well, and so in those first 1 to 2 stages of endometriosis, we talk about, there's a super high prostaglandin activity, because the body is kind of attacking those lesions or those deposits outside of the uterus. And so that's kind of the first part of the problem, is the inflammation. In the later stages, you can start to get scarring and adhesions. This can, block your fallopian tubes, kind of distort anatomy. It can adhere ovaries in odd places. It can distort how the uterus is kind of tilted. If you have endometriomas, there are a few things that can get into kind of your storage of eggs. We know chemotherapy is one of them. If you smoke, that can decrease your egg count. Endometriomas are another one of them. So, once you have that and you're in those late stages, not only can you have blocked tubes, your ovarian reserve, we know, decreases quicker. It can affect egg quality. We also think it can affect embryo development, because those eggs and sperm are meeting in the tube, and it takes about 5 to 6-ish days to get to the uterus. And so it's spending all of that time in this toxic environment. Same with IUI, it's still exposing it to the tubes. And so especially in those later stages of the disease, we are recommending IVF. And you Did you ever, like, you never had, like, endo or thought you had endo or anything like that going through this process?
Yeah, so I have had like suspected cystic spaces, like noticed at certain times on ultrasounds, kind of from my first fertility clinic. And so, we did the Receptiva, it was negative. And so at that point, we just kind of put it away and thought, okay, well, like, maybe it's just a malformation. It's not, a big deal. And then when I came to CNY, and I talked to Dr. Kiltz about it, and he was like, well, Receptiva is a great test, but it's not 100% accurate. And so I guess I never thought about it before.
Yeah.
I was like, oh, okay.
Yeah.
Because once that came back negative, we just put all that aside. Like,
Yeah.
okay, well, it's negative. And then, Dr. Kiltz was like, I don't, yes, it's a great tool, but it's not foolproof. That doesn't mean that there's not suspected adeno or endo. And so I've never truly been diagnosed, but I have had obviously multiple SHGs, and sometimes they look great, and then sometimes it's like, oh, there's like a little spot that kind of looks abnormal. So it's like hard to tell, I guess. Yeah.
Well, okay, so you actually brought up Receptiva. So that is a biopsy of the uterine lining, and it checks for a protein when we're looking for endometriosis called BCL6. So as far as endometriosis affecting fertility, we talked about tubes, the toxic environment that the embryo is in, ovarian reserve decreasing, but we don't really know. So the question, I guess, would be, endometriosis is outside of the uterus, so how is it affecting implantation in the uterus? And the answer to that is right now, we don't really know. Is the lining of these people, or are they different than those without endometriosis? We have found, and this is why the Receptiva test is around, that those women with endometriosis will actually have higher levels of the BCL6. And so that gives us kind of a clue of, hey, this patient might have endo. But, yeah, you're right. Just because it came back negative doesn't mean you don't have it. And just because you came back positive doesn't necessarily mean you do. It's just kind of a tool. But those patients with unexplained infertility, a lot of them will have endometriosis. So sometimes, even if they don't have symptoms, I'll say, you know what, we're just going to presume you have it, and we'll treat you like it. So, and that's kind of where the suppression comes in.
And that's exactly how I came to be on Lupron.
Okay, so you bring up the Lupron thing, and we're actually going to go into. Okay, so this is I'm trying to figure out how to set this up. So, in those people with recurrent implantation failure, and I consider that 2 to 3 failed euploid embryo transfers, because endometriosis doesn't affect implantation in everyone, but in those that it does, we typically recommend doing the suppression, which is we're suppressing hormones. We're kind of putting you into a state of menopause for 60 days. Now, you can do this with Lupron Depot and sometimes some add-back, or Depot Lupron with some add-back letrozole, or Lissa or Myfembry or other ones we use. A lot of patients are afraid of that too because of the symptoms. Because you did it with the Lupron. What side effects did you have or not have?
So I had like read and about like, oh, Lupron's like the worst drug ever, and honestly I was more concerned about my mental health than anything else. And so I didn't do the Lupron Depot. I opted to do just a daily injection of Lupron. That way, if it started to affect me to where I was like, this is not going to work, that I could just stop it. So that is an option. Not everyone opts for that, obviously, because Lupron Depot, one injection a month versus the way that I did it, which was an injection every day. At this point in my journey, I had taken so many injections, I don't care. That's what it is. Yeah. Recently, like, I was put on progesterone, and I was like, no, I'll opt for the injection. No suppositories for me.
Yeah.
That's my preference, though. But so I was really concerned about my mental health. I didn't find that my mental health like struggled as much as I was expecting it to, and maybe because I had kind of like prepped myself, then I was, more cognizant of like making sure I was getting what I needed, getting some vitamin D, getting some sunshine, whatever. But I think the worst symptoms for me were just like kind of like body aches, so like joint aching, and night sweats. I think those are probably like the two things that like were the worst symptoms for me. I dealt with the night sweats by just like getting one of those little fans that go on your neck. My daughter was like, "Mom, are you serious? Like, do not let anybody see that." She's like, "I can't believe you're doing that." She was so embarrassed. Anyways, I was like, I'm in my bed. Like, what's the problem? Go to bed. Like, go to your room.
Yeah, you're in my space.
Right. But, and then the body aches, like I, over the counter but it wasn't nearly as bad as, or my experience wasn't nearly as bad as kind of what I had prepared myself to deal with. So I was pleasantly surprised that it wasn't what I thought it was going to be. So, but I know some people, obviously it affects them differently. And so they may opt for something like Orlissa or my Fembry, as an alternative, which is an option as well.
Yeah, and just like you said, your experience is just that, your own.
Right.
And I always tell people, you may handle it, your body may handle it better or worse, or
right.
it just everyone is different. So I think, finding a method that works for you is important. And yeah, whether that be the Lupron, which we can do some letrozole to help with kind of some add-back hormone, or my Fembry or Orlissa, that kind of helps decrease that inflammation, and that's 60 days before an embryo transfer. And it's not a first-line treatment, so if you have endometriosis and you're wondering, hey, I didn't have 60 days of suppression, again, it's just because, we know that it doesn't affect implantation in everyone, but in those that it does, we see that this helps.
Yeah.
I get a question a lot about, should I have my endometriosis, should I have the surgery, or should I do the suppression? Surgery obviously is the gold standard for a diagnosis, besides, if we see an endometrioma on ultrasound. So the good things about surgery is that, one, you get confirmation that, hey, you do have it, and we can kind of see what stage you're at, and we can excise it or ablate it, take this out. But that typically, studies have shown that for fertility purposes, it really only helps in the first 2 stages. We know that secondary surgeries, even if, so let's say you get relief of symptoms, and now it comes back and your endo is worse, a secondary surgery can actually decrease fertility outcomes. It does not help. So if somebody's already had a surgery and they say, well, what if it's come back, or I need to do it again? Unless it's debilitating and we're really just trying to control symptoms, my answer is always no, let's not do that, because we're just going to start to decrease egg reserve. We're decreasing fertility overall. So
then we would suppress, right?
Yeah, so, and I'm going to go over statistics a little bit, and I have them all written down because they're kind of a lot. So we'll start with people that are not trying to or they are trying to conceive, but they're not doing IUI, they're not doing IVF. Okay. So unassisted at home. So with people trying to do natural conception, if they're in stage 1 or 2, and have surgery, within 3 years, 47% will conceive with surgery. With stage 3, 33% will conceive, and with stage 4, 0% will conceive. So if you're older, because remember, age is still a factor with everyone. If you have other factors like male factor, or you're on stage 3 or 4, surgery, if we're not trying to control symptoms, it just may not make sense for you. In women that are under the age of 35 with endo, they're twice as likely to have infertility than those without, but they may still conceive unassisted. And the average rate of conception in a group without it is 2 to 10%. And then when the average is about 15 to 20%. Now, with unassisted, without surgery, with stage 1 or 2, 50% will conceive. With stage 3, it's less than 25%. And then in stage 4, it's very low. It's even lower than that 25%. If you're going to do IUI, which usually in patients with endometriosis, I'm just jumping to IVF because we also have the added benefit of banking embryos. But in those with stage 1 or 2 endo that want to do IUI, you do have better outcomes if you use Clomid or letrozole or gonadotropin, so the injections. 8 to 10%, that 8 to 10% success rate in those with unexplained infertility is what we're looking at. But if you also have endo, that rate is lower. If you have surgery, you can get up to that 8 to 10% range. So you're kind of up there with the unexplained infertility. Mm-hmm. So I guess you have to decide if that's worth it to you. And sometimes it can just delay treatment and getting to IVF.
Sure.
So usually if somebody has stage 3 or 4, or we have more factors, or we need genetic testing, then we are recommending going straight to IVF. Let's see, what else haven't we gone over? We do know, that surgery doesn't always improve outcomes. Like I said, it doesn't harm implantation in everyone, and there's no actually increase in miscarriage rates with these patients. A lot of people will ask about not only surgery for that, but should I have this endometrioma removed or excised before an egg retrieval? So women with endometriomas that were excised before egg retrieval actually got the same number of eggs retrieved. They have the same pregnancy and live birth rates. So there's actually no evidence that excision or endometrioma removal is helpful if your plan is to go straight to IVF. So usually I'm just doing what you did and suppressing people and saying, if we're not managing symptoms, let's not do surgery.
Are there times that it's applicable to suppress someone even after they had surgery?
Yeah, so I would say, if you had surgery years ago, mm-hmm. And you haven't been on birth control, or even if you have, and in between trying to conceive, and now you're having that recurrent implantation failure, usually, yeah, I'll suppress. But again, it's not a first-line treatment. Mm-hmm. But if it was a long time ago that you had that surgery and you are having this issue of recurrent implantation failure, yeah, I will usually suppress people.
Okay.
Supplements, obviously, and lifestyles. We talked about, not smoking, optimizing stress, getting enough sleep. Supplements are a big thing as well. So usually CoQ10, vitamins C, D, and E, mm-hmm. N-acetylcysteine, and a prenatal with at least 400 micrograms of folic acid are usually good supplements, especially for those with endo. And then again, pain management strategies just for quality of life. So obviously you can't be on birth control pills if you're trying to conceive. But, even if you're doing IVF, it's us choosing protocols that can manage inflammation. So Lupron cycles for those kind of with a normal or lower ovarian reserve, Lupron stim cycles. And then if you have too high of a reserve, or higher of a reserve, we're still using those antagonist protocols like with ganirelix or Cetratide, or even Provera. Let's see. So I guess, a lot of key takeaways from this are that, the earlier caught, the better. Mm-hmm. So, seek out a second opinion. Let's work on catching this or maybe treating it before it gets bad. Managing symptoms where we can. So if pain is debilitating, maybe that does mean surgery for you. Banking embryos, so that way, if that ovarian reserve starts to decrease, that we have embryos banked. And again, individualized care, treatment plans, like I said, depends on whether you're trying to conceive or not, what stage you have, whether you want to do IUI. You may not need help at all. So endo is just a very complex process. It's hard to get a diagnosis because it is a surgical diagnosis.
Yeah.
And, not a ton necessarily is understood about it.
I see on social media quite often, like in local groups that I belong to, just like women's groups on Facebook, people commonly asking for an OBGYN that specializes in endometriosis. And I think that's partly to do with like, maybe they tried to address it in the past. They know that something is not right. They suspect, hey, I think that this is something that I might be experiencing. But it has been brushed off or just like not addressed to the, in the manner that they feel like that it should be addressed. And they're still suffering every month, and like you said, like maybe they're missing school, maybe they're missing work, maybe they're, missing social activities, like they're, in the bed for a few days a month. Obviously that they know something is amiss. Like I'm recognizing that other people are not living like this. And so I think that's really key to just empower yourself to, if I'm not getting answers, it never hurts to seek a second opinion, or a third or fourth.
Yeah. Well, and the thing too is like, I know they ask about like here, which people specialize in endo, and surgeons are obviously different because there are surgeons that specialize in excision or ablation or however they remove it, which there's no difference in outcomes based on how it's removed. But for the most part, everybody I feel like that works in fertility is pretty well versed in endometriosis, because a lot of it is the reason you got here. You have this scarring. Sometimes if you're doing a bimanual exam, you can feel these like hard lesions behind the uterus. If we're doing a transvaginal ultrasound and I notice that, hey, your uterus is tilted kind of weird and your ovaries are kind of staying stuck in the same place, those are keys to us that start to clue us into, hey, this person might have endo. So if you have symptoms on top of it, kind of a red flag is going off in our head. So everyone here, I know at CNY, is well-versed.
Right.
And that should be true for all fertility clinics. We always have endo in the back of our head. But yeah, if you're going to just a regular primary care or a regular OBGYN and you're just getting the kind of, oh, well, like that's a normal thing, you're right. It is okay to seek a second opinion, because the longer you go, you don't want to go that 7 years average that it takes to get that diagnosis, because it's just consistently getting worse.
And I mean, what kind of quality of life is that? When you're having to miss multiple days a month of school or work, or even if you're missing one, and there is something that could help you, why wouldn't you want it to be addressed?
Oh yeah, and in pregnancy, back when, a long time ago, probably not that long, when endo wasn't, like you said, it was being treated as hysteria. Yeah. And we didn't know why women were having these periods, but we found out, hey, when they're pregnant and not having periods, they don't have these symptoms because you're not having these lesions that are being stimulated by estrogen, and so you're not having the symptoms every month. They would tell women, oh, you need to go get pregnant. We just go and try and have kids. And not everyone wants to do that. Not everyone, So,
or even if they had a child and they love their child, maybe it's not right to have another one. And like, how long are you going to be able to sustain that? And then that's not really. Yeah, you can. That's not a good reason. So I'll just keep getting pregnant.
Well, and we've talked about this so much. And it drives me nuts when people post about birth control being bad for you and hurting your fertility and toxic and all of these things and post-birth control syndrome, because this is truly life-changing for these people with endometriosis that aren't trying to conceive. It treats the disease. It prevents it from getting worse. It actually lowers your risk of ovarian cancer pretty drastically.
And there's several different types of birth control. So like maybe not, not every birth control type is applicable for your situation or for each person. But we have several different options.
Yeah.
And so, yeah, birth control is not the big bad wolf.
Yeah, and progesterone only options can also, be helpful because we're not stimulating those deposits either.
Right.
But you have to be careful. So things like the Mirena IUD, technically it thins out the lining and it can prevent ovulation in some people, because remember, we're not wanting those cells to get in the ovary. But it doesn't prevent ovulation in everyone. So, and obviously copper IUD is not going to do anything because it's not hormonal, but you're right, there are options. Just because somebody had a bad experience with it doesn't mean you will.
Right.
If you're somebody who can't have estrogen because you have a blood clotting disorder, yeah, there are progesterone only options. But I feel like, when people spread that kind of false narrative, it prevents people from getting treated and it does affect their quality of life.
Right. No, absolutely. Yeah. I mean, I've come across so many different women in my lifetime who thought that they had to live a certain way and, and just had super painful, very, very, very heavy periods. And, it definitely does affect your life. And, for several days out of the month, that's all you can focus on.
Yeah.
And so there are options out there to help alleviate some of that.
Oh, yeah, and it's already hard because I have friends that always joke, like, okay, I have, like, the 2 weeks before my period, I'm miserable because I'm in the luteal phase. I'm, like, broken out. I look ugly. I'm like, mad at everyone. And then I'm bleeding. That's miserable. I can't go anywhere. And I have, like, 1 to 2 weeks out of the month where I feel okay. Yeah. And that's awful. So.
And then you're kind of recovering from what you just went through.
Yeah.
It's like, when the hell do I feel normal?
I have one good week where you could catch me.
Right.
Yeah. So, early recognition of it, treatment depending on where you're at in life is important. Knowing that just because you have it doesn't mean that you're going to struggle.
Yeah.
Not wasting time sometimes with surgery or IUI when we could jump to IVF.
Being proactive about it. Yeah.
Yeah. And actually interesting. So they did a study of people with endo and those without. And these were medicated frozen embryo transfers of blasts. Those with endometriosis and those without had the same, and this is age related, so the same ages in the same groups, had the same aneuploidy rate depending on age, and they had the same pregnancy and live birth outcomes than those without endometriosis. So that's why I say, it doesn't necessarily affect everyone the same.
Right.
But in those that, that do have implantation issues or, adhesions, there are different ways to treat different people depending on kind of symptoms and what the goals are.
Yeah, and that, what we talk about all the time goes back to just like being open and honest with your provider, finding a provider that you feel comfortable enough to be open and honest with, opening up to them. Even if you feel like that something is maybe not relevant, just mentioning it. If it's not fine. But, having, all the pieces of the puzzle to be able to make the best treatment plan to move forward for your individual care is really important.
Oh, yeah. And, mentioning painful periods or, hey, my mom or sister has endo.
Right.
Usually we'll ask, but, if for some reason you weren't asked, or some people won't bring up the pain during intercourse because that's embarrassing and I don't want to. And I mean, a normal part of life, and if that's like a symptom you're having, one, that's awful to live with.
Right.
And two, that clues us into, okay, well, something else is going on that's not normal.
And we can
help
ask
you
more
get
questions.
treatment. Yeah, and diagnosis faster.
Yeah.
So, find a provider you're comfortable with, and any symptoms that, even if you're not sure are normal, bring up.
Absolutely.
I think we hit a lot of the key points as far as what it is, how we diagnose it, different, treatments and impacts on fertility. Hopefully this was helpful. Laura, do you have anything else that you kind of want to add or that you could think of?
No, I think that just kind of in summary, if you think that you're experiencing anything that's outside of the norm, obviously most women have, some type of female relative, friends, coworkers, and that they can kind of compare their experience to. If you feel like that you're experiencing things that are outside of the norm, please find someone that you feel comfortable with discussing that with, a medical provider. And if you don't feel like that you're being heard, please, seek out another opinion.
Yeah, and, same kind of thing as far as IVF goes. If you have recurrent implantation failure, which we think we've done an episode on, if that's a problem that you're experiencing and you want to just, even if you've had a negative BCL6 and you want to suppress for 60 days and just try it, I'm one that's pretty open to doing that. I think most of our providers are. There's really no harm in doing it other than 60 days and maybe some side effects, but ask for that. If you want to try suppression, ask. I'll never really say no to that. So yeah.
Yeah, I think the worst part of it is just waiting 2 more months for a transfer.
Yeah.
Like to me, that's the worst part of it.
Yeah, so make sure you have embryos banked first, and then I have no problem adding that on for whoever, and I know everyone else is pretty much the same. So hopefully, if you're having these symptoms and you even haven't tried to conceive, but you're in that group to where, every month it's debilitating, hopefully this episode helps you to reach out and decreases that 7 years to diagnosis for you.
Which is wild.
I know. All right. Well, hopefully this is helpful, and we will see you guys next week.
See you next week.